We're at the IAS meeting in Vancouver, BC, and we're here with Matt Freiberg from Vanderbilt University, associated with Vanderbilt University in Nashville, Tennessee.
Great.
And we appreciate you taking the time to talk with us about cardiovascular issues in HIV. And
Sure.
Near and dear to my heart, it is an issue because I just had open heart surgery.
Oh my gosh.
And but it's important for me to hear this, as well as our audience out there.
Sure.
One of the major issues that we deal with in HIV. So
take it away.
Take it away.
Well, I think there's a lot of things that are happening now, and I think the big thing is that as HIV's transitioned into more of a chronic disease, cardiovascular disease is going to become more and more common. And while a lot of the attention has been focused on the virus itself and the treatment, and that's starting since about 2003, and no one's disputing that, I think as people age, other things come into play. Diabetes, hypertension, smoking, blood pressure, all these things matter, and they're going to continue to matter. And I think the first thing we just had a session we wanted to talk about is that in addition to getting the HIV under control, if you have it, and getting yourself virally suppressed, if any of these conditions exist for you, or if you haven't been screened for them, that's the first thing I would tell people to do. Because we know in the uninfected population, we know they drive risk. And what we're finding is that, you know, people sometimes get so obsessed with making sure we've got all the HIV, that disease taken care of, that we've stopped taking care of the patient. And there's all these other things that happen. So that's the first thing I would say is really important to understand. And I think that's where we're going. And that means people following guidelines. It means making sure that the care is delivered in an adequate way. And I think that's the new phase of research that you're going to see. And the reason I think it is because we're already seeing data that suggests that there may be differences in care, and it's not clear why. Whether it be receipt of aspirin, receipt of statin therapy for lipids, receipt of aggressive cardiovascular procedures like coronary artery bypass grafts, may not be the same for HIV infected and uninfected people. And we're not sure if it's the data we're collecting isn't good enough or there's really a difference in care. But we need to understand that, because that is going to be very relevant as we keep moving along with this disease and people with this disease get older and we start seeing some of these other disease processes happen.
So in the workup that they do when they introduce a new patient, or even maybe review a patient's history, do they look into the family histories and so forth? Do they ask all those questions?
Yeah, and you know, I can't speak for everybody, but yes, they should be. A person with HIV should not be treated any differently with regards to how we approach them. So when you talk to a patient, you ask about why they may be here for the particular clinic visit. But people should be asking, do you have any past medical history, any surgical history? Do you have any family history with regards to cardiovascular disease? What medications do you take? What allergies do you have? What kind of social history is relevant to you? Meaning, do you smoke? Have you ever used any kind of drugs that may be relevant to cardiovascular risk? All of those things matter, and everybody should be asked that. And even though it seems incredulous that you'd think, like in the United States as an example, everyone has their blood pressure checked, everyone has their BMI checked. You know, that may or may not be true depending on where you are. Depending what resources the clinic you go to has. Is it, you know, a free clinic, standing hospital structure, whatever. So you should be asking, have I ever had my blood pressure checked? And if so, what is it? Have my lipids, have my cholesterol ever been checked? And if so, what is it? Have I ever had a blood sugar checked? If so, what is it? Because if you don't screen, you can't detect. If you can't detect, you never get treated. If you don't get treated, you know what the outcome is.
Bad news.
It's bad. So that's kind of one of the messages we were talking about in the session today, whether you're a high-income country, middle-income country, low-income country, is, you know, screening, detection, treatment. You know, not only HIV, but all these other things I just mentioned.
It seems as though it's always prevention of dealing with people with risks, appropriate prevention, prophylaxis as well, which you would be doing with various statins and so forth. Is it I guess it's cost effective. So I mean, that's
question.
the important thing. I mean, we don't seem to really acknowledge that as much as we should. I know we do about HIV, and even with the hepatitis, as expensive as it is, it's still cost effective. bottom line.
So, I think prevention is the only way that's going to make any sense for anybody, because if people are living long enough, I mean, a person who lives with diabetes for 30 or 40 years is going to have a lot of complications, regardless of HIV status, or
They're gonna be in
smoking
the
for 30.
hospital a lot of times,
Yeah,
yeah.
absolutely. And there's costs everywhere. So it's not just a financial cost, but look at caregiver burnout. I mean, it seems kind of unrelated, but you
Out of
got-
work.
Absolutely, you lose time
Other
at
people
work.
out of work because
they're taking care of you. Exactly. So there's a lot of costs that don't get factored into a lot of the analyses that people do. It's complicated to put all the costs in. So it'd be just better if people didn't, if it just didn't happen to begin with.
Right.
Correct.
So how do we accomplish some of these? I mean, because we're talking about two things that I always look at through the health programs that we have through Health Challenge is nutrition and exercise. They're pretty obvious. Those are two things you can apply almost anybody. There's no one that is immune from
Right.
being.
Why wouldn't you want to
Yeah,
do that?
exactly.
I think there's a number of things. I guess there's that has to happen. I think there's a sense of an awareness on the patient's part. My patients know what's going on with them better than anybody does, and trying to take an active approach. The second piece is getting physicians to be engaged and make sure that they're treating HIV-infected people like they do anybody else, and that routine screening gets done. There's healthcare systems. What can we put in the electronic health record to help us remind if there are special reminders, things that need to be done? So we think of it as systems level factors, patient level factors, provider level factors.
Right.
And if each of those things are operating appropriately, we should be able to accomplish what we want. When you miss one of those things, you don't get what you want. So example, you can have the reminders in the electronic health record, you can have a provider tell a patient what should happen, but if the patient doesn't want to exercise, doesn't want to take charge of some stuff, or has limitations and can't, and they don't get help, you don't get to the end, you don't get the end result you want. So that's kind of how I break those three things, and they all have to work together to be maximally successful. So I think that's the approach I would look at. That's the 50,000-foot view. The 10-foot view is also remembering that while we've got all these guidelines that we say, this is how we take care of a population, everybody should have this. But at the end of the day, it's still down to one patient and one doctor or provider. And you've got to take those guidelines and try to apply it to your one person and make it work for them as best you can. And so one of the things that doesn't come up a lot, which is really important, is risk reduction. So I'll tell you what I mean by that, and it's really important. So my wife is a tobacco expert, doesn't do HIV, does tobacco. And tobacco is a highly addictive substance, and it's hard to quit. She'll say, she may have a 2-pack-a-day smoker. Instead of, not that you don't want them to quit, but if they got down to 1 pack a day, that's still success. And sometimes that gets tossed out the window because you didn't quit and you didn't get this done. Instead of saying, hey, we just cut this exposure down by half. And that may have some serious benefit. And that goes for almost everything. Your lipids may not be perfect yet, but we've got it down, let's keep working with it. I think that concept of risk reduction sometimes gets lost with patients. They feel like if I can't get the perfect end result, I might as well just not
blow it off.
bother.
Yeah,
And
exactly.
that's not, I don't think that's where we should be going, because who's perfect? We just keep moving towards that goal. And so I guess that would be something else that would be really important for people to understand, because you have power over that. Like, okay, I'm not perfect today, but if I keep working it, I might get there, and I'm still helping myself by reducing smoking or reducing my blood pressure, reducing my blood sugar. You get the point.
Right.
And if we can emphasize that, it's a good thing.
And the one-on-one with the doctor is really where it's at. But
Absolutely.
But I'm thinking, is it possible that you can see the benefit? For some people, that's all that needs to happen, because they're self-motivated.
Absolutely.
Or whatever. But there may be people that need a buddy or a support group.
Absolutely.
How do you fashion that in? Is it?
I don't have as much experience in that thing, but we call it community participatory research, so some people and experts in that. But they use the environment they're in as a means of improving their outcomes. Let me give you an example. So there was a study that they wanted to try to go after high blood pressure in young African American men who historically weren't necessarily coming to the clinic. So they brought the blood pressure to barbershops, because the men were going there routinely.
Right, and they're sitting around waiting.
That's
yeah,
right, and
yeah.
and they're there, and they put people in that space, and the men are like, well, I'm already here, and you can check my blood pressure, and that's fine. It's that engaging the community where there may be opportunities. Church groups are another place that some people go to. But I think that that's one way that that could be accomplished. And though it's not my area of research, I see the value in it. And then the other thing is, you've got networks, whether it be friends or family, and you've talked about it. Those people can often be powerful motivators for a patient. I mean, I can say something like, let me give you an example. If there were 2 people coming into my office and one has whatever the disease process is, and you don't feel like you're connecting with them. If you connect with their partner, and their partner says, I want this person around, so what do we need to be doing? You may find that you can be successful that way. So there's a lot of different ways to do this. There's no one right recipe.
Right, right. Well, I don't know if we've covered everything you need to cover, but it seems as though we've gotten, the audience has gotten a good picture of the cardiovascular risks, of also what they may need to do and what considerations they may need to make to improve their health. And I really appreciate you doing this.
Absolutely, my pleasure.
And certainly for coming to the conference and bringing this piece of it to the conference.
Thank you.
Because the metabolic issues are major importance.
They are.
And it's one of the things we have control over.
Absolutely. I don't underestimate the power of the patient.
And we want the patients to be in control.
Absolutely. I agree.
Thank
Thanks
you so
much.
much. Yeah.
Pleasure.
Yeah,
Thank
yeah.
you.